Hello, friends. Yes, here we are. Welcome. Night is falling over Amsterdam, as you can see behind me, as this is the close of this day, the closing of the last day of DevDays US 2021. But don't worry, we still have a very interesting 45 minutes to an hour for you. And let me guide you through those last 45 minutes. So first off is Michael Wang from the University of California, and he's going to talk to us about EHR access logs for evaluating burnout. I'm looking forward to that one. Michael had the weird honor of having a meet and greet before he actually has done his talk, so we already had a talk before this. So, I'm really looking forward to what he is going to say. After that, something completely different. We'll give the word to Dave, and we'll have a roundtable. What do patients and doctors need from us developers? So that means that I'll stick around, as a proxy to represent all the developers behind my back, you, and we'll have a talk with the doctors, what they really want from us. Then again, after that roundtable, we'll pass the word. Yes, please. We'll pass the word to. Thank you. We'll pass the word to Grahame, and this is an old habit. I think Grahame Grieve has given the closing keynote at every single DevDays. So this must be his closing keynote number 12. And I think my clicker has had enough of it for today. The last slide though is interesting because if you, thank you. After that is a thank you and a drink. So stick around after Graham's farewell words. That must be around 10 minutes past 5. I'll show here you have a picture of what it used to look like. We're going to try and do this again with the social things that we have available, which is our spatial chat. So on the next slide, I have the address once for the last time. Probably your browser remembers it by now. We'll have multiple rooms, so we can all have a drink. So stick with us, please, after, if you feel like it, just like in a normal conference. And for now, I think there's little left to say than just kick this off and give the word to Michael.
Okay. All right. Thanks, everybody, for joining. I'm going to share my screen and go ahead and get started. Ewout, is this coming up?
Yeah, it is.
Okay, cool. All right. So thanks, everyone, for joining me for the last of the Doctor Track sessions in this closing session. My name is Michael Wang. I'm from UCSF, and I'm going to be doing a very quick presentation on EHR access logs for evaluating burnout in the clinical setting. This is a quick description of who I am. I'm an assistant professor in the Division of Hospital Medicine at UCSF. This means I'm a practicing hospitalist. I do see patients who are admitted to the hospital overnight. And I also do research with the Center for Clinical Informatics and Improvement Research. We should call it CLIR for short. And this is all based at UCSF. Our research group focuses on the access log and how physicians interact with EHR. So I'm going to be doing a very quick run through of sort of the type of work that we do. So for our learning objectives, I'm going to very quickly going to go through just just defining what access logs are and what types of data they capture, sort of the why, explaining how these access logs can be used to address burnout in clinical settings, and then the how, explaining some of the limitations and tricks to using access logs at scale. So with that, I'll just get started with the what and talk about what access logs are. So this is a very messy slide. I'm not going to ask anybody to read this. These are basically regulations for EHRs, as far as what the regulatory requirements are for keeping track of activity logs. The main points here are that they're capturing login monitoring. This pertains to information systems that contain or use PHI, and they ultimately have to manifest these logs as either audit logs or access reports that are available for review after the fact. Apologies to anybody who's here from OpenEMR. I grabbed a screenshot from you. So just to make this feel real, let's imagine I'm a doctor and I'm logging into this patient Susan Reynolds chart, and then I go in and open a vitals little widget here. Ultimately, what the access log might look like is Dr. Wang logged in, then Dr. Wang accessed this patient Susan Reynolds. This is their associated MRN, and then ultimately it'll show like this Dr. Wang viewed this patient's vitals, right? So the access log may look something like this. Here's just like a more longitudinal view of what this might look like. Here you have a swim lane for each patient, and you can see that they all have sort of multiple events of different types. It could be physicians looking at just reading data. It could be physicians writing orders. It could be writing documentation with multiple event types for each of these patients. And really, each of these events basically captures, who's the person who's doing the action, what patient they did the action on, when they did it. There's a timestamp, and then some label of what the type of event they did. So now that we have a sense of what access logs are and what kind of data they store, how can they be used to address burnout? So I'll walk through 3 separate examples here. So this is one figure from a colleague of mine at Stanford, Jonathan Chen, and we're going to focus on orange line here. But basically on the y-axis, we have the number of actions happening in a 15-minute block. On the x-axis, we have the time of day. So we're focusing on this orange line. These are interns, first graduates out of medical school. And one thing you can use access logs for is just to figure out how long are they spending in the hospital, right? Because you can measure how often they're clicking into the EHR. So you can see these interns tend to get in around 6:30, and then they do quite a bit of activity during the day, and it really doesn't start to lag off until about 6:30 at night. So even the fastest interns are probably spending at least 12 hours in the hospital. And you see that this lags all the way out to even like 12:30. So some interns are having 18-hour days. They're coming into the hospital at 6:30 and going all the way out to 12:30 at night. So this allows you to just generally see what the overall the activity burden is for individuals, and potentially target specific individuals for being especially slow, to give them help, help them with give them support so that they can get out of the hospital earlier and be less likely to burn out. Here's a second graph. This is one I made at UCSF. Basically, this graph is trying to explain what proportion of notes do physicians look at. We're trying to basically assess how much data overload physicians experience. So this blue on this y-axis, for the blue bars, it's the proportion of notes that are viewed. And on the x-axis, this is the number of notes that are available. So you can see physicians do a fairly decent job of looking at notes when they're available. There's not that many of them. We tend to look at about 20 to 30% of them. But once you start to get out to like patients with really long charts, 100, 200, 300, 400 notes, our maximum patient had something like 2,000 notes in their chart. Physicians really just can't keep up with all those notes. We're not going to look at every single note if a patient was 2,000 notes. And that the overall percentage, because of how much note volume there is in the chart, it comes out to about 3.5% of all the data that's available from the notes. And you see that physicians do try to keep up with the number as there's more data. We do look, this orange line represents the count of notes that we look at. So we do look at more notes, but we just can't keep up with the, that volume of data that's available. So there's both this evaluates both the data overload component of physician burnout, but also presents an opportunity for developers. So if some smart developers wanted to go in and start modeling which notes I want to look at, you could potentially start to train that and surface that to physicians to make us more efficient. The last use case I'll explain here is really measuring the impact of UX changes that happen in the EHR to measure impact. This is effectively A/B testing in the clinical setting. So this is a study I did with Dr. Edler Milstein a couple of years ago. Basically, the y-axis here is the number of outside records viewed. This is the number of notes and labs from other hospitals besides UCSF that we're looking at in our own EHR. So this gray line here is sort of the number of view events per week for the old way of doing things. And then very clearly here, we have a black line here representing the new way of looking at these outside records that started in week 27. And what we see is that, in week 27, there's a huge spike in outside record consumption with this new method. And if anything, there's a little bit of growth in the old method of viewing outside records too. So you almost end up with like a doubling of the number of outside records reviewed because you implemented this new, easier to use UX for accessing outside records. So you really can start to evaluate the impact of your UX interventions with access, good, well annotated access logs. So that was 3 examples of how access logs can be used. Let's talk about some of the limitations. So going back to my open EMR example, so let's say, I kind of assumed in my previous example that, when the doctor opens a patient's chart, they have to click on a button in order to open this vital panel. That's not always the case. In some cases, and actually in many cases, a lot of these vitals and other data may be open by default when you open a patient's chart. And this really leads to this discordance between whether the information is just being passively displayed or if the physician is actually looking for information. So if you're just looking to see, is data being exposed to physicians, it's okay to just use these events as information display. This is sort of what they were meant to do from a HIPAA regulation perspective, is just tell you when data is being accessed. But if you're really doing UI, UX research or A/B testing, you want to see, is a physician like clicking, intentionally looking for this data? That's not always going, you really have to understand the workflow in order to make sure that this event is equal to information seeking. So that's something that requires a lot of validation, a lot of front-end sort of like reconciliation. The other major barrier is sort of event semantic interoperability. So if let's say you are hospital A and you do a lot of this validation, you figure out here are the 4 codes that correspond with a physician looking at lab results. It could be that even with the same EHR vendor, hospital B lab results are actually correspond to a whole different set of event codes. And this could be just based on configuration differences between hospital A and hospital B. And what we found is that even within hospital A, you can have differences as well as configuration changes happens, as upgrade happens. This set of events that describe a certain clinical phenomena are not always consistent. So that also makes this tricky to do, even over time at the same hospital. So what can devs do? I mean, I think most of the people on this meeting are devs. I assume most of you are not EHR devs, but even with, I would say I see this a lot in my product roles with devs who are building out new applications, is they don't actually think much about it. You don't think about this instrumentation until you've acquired a decent amount of technical debt. So what I often say is, instrument frequently and intentionally. Keep an eye. I see a lot of times developers assume they can just take timestamps of data access from Datadog or other data access logs to calculate how long someone's spending on a screen. I will say in most healthcare settings, because you log out so frequently, that's not usually a reliable way of calculating times. A lot of times it's better to actually have a more active measurement of time spent on certain UI components or screens. The second thing I often see is people aren't thinking ahead to what they will want to A/B test. And they acquire a lot of technical debt just building in the A/B testing after some things go live. Whereas if they kind of did the instrumentation as they're building out the UI, you don't have to do all the validation. You save yourself a lot of time that way. The last suggestion I have to devs is try to make your event categories make sense clinically. Instead of just labeling a certain data event as data event 1, 2, 3, be like, okay, this is a lab. So either have a hierarchy or just be intentional with your naming of event types. So that's been a quick whirlwind tour through access logs, EHR. Hopefully you've learned what EHR access logs are, which is login events and data access activity within EHR systems. I've given you 3 examples of how they can be used to address burnout, which is measuring time spent in the hospital, evaluating what data doctors want to see, and then evaluating the impact of UX changes. And then explain some limitations to using access logs at scale. And so the 2 main ones I talked about are that information display is not always equal to information seeking, and there's major issues with event semantic interoperability. So that's all I have. Here's my contact info. And let's see, do we have time for like 1 minute Q&A, or should I just pass it off?
can just pass off.
Okay. All right. Dave, I'll pass it off to you for the panel.
Great. So for the moment, we will just take a look at my video. And I think I'm going to switch directly over to John is going to be sharing his screen. This is where it all comes together, right? This is the patients and doctors saying what we want from developers. And let's see, there we go. So if you could pop to the next screen. I'm going to be moderating. I think the gentleman on the left needs no introduction here, but we're going to have two of the keynoters from the patient track and the doctor track in this 20-minute roundtable session. And so just by way of introduction, I'm going to, both Katie and John will present a few slides of their own, and then we will get into discussion. So Katie, go ahead, unmute and narrate these few slides.
Okay, you got it. I am Katie McCurdy. I'm a designer, patient, and founder of Pictal Health. I live in Burlington, Vermont, and I'm in the airport on my way to Michigan, where I grew up. So I started Pictal Health to help people with rare, complex, or mysterious health conditions to tell their health stories in a more visual way. This really came out of my own experience and need as a complex patient. And my goal with the company is to help people communicate more effectively with their doctors so they can be heard and seen and understood as they're trying to get the right diagnosis and treatment. So next slide. And so this is a zoomed out view of what these timelines look like. And John, you can go to the next slide. And just to walk you through in brief, some of the maybe atypical type of health history data that's here, we map out people's symptom history. So the graph at the top is someone's memory of how their body was feeling and how their symptoms were feeling over their whole life, going all the way back to birth. And so this is not tracked data. This is really just a visual representation of someone's memory of how they felt. Below that are diagnoses. And then if you go to the next slide, the yellow bubbles are life events, and how large they are is how stressful or how big of a deal that event was to the person. And then below that are treatments and interventions the person has tried, not only medical or prescribed treatments, but also any intervention like saunas or dietary changes. So if you go to the next slide, so this just gives a holistic view of where someone has been, what they've tried. This is also a super simple version. Usually these are much more complex and include other health data like surgeries, procedures, test results, things like that. But what this does allow us to do, next slide, is see the big picture and also start to make correlations and understand slices in time and how things like moving to a moldy house or having a stressful life event may have contributed to an onset of their symptoms. So we can start seeing new patterns that we couldn't see before. So that's it in a nutshell. Thank you.
Okay, awesome. Thank you. I guess I will introduce myself. I'm John Manning. I'm a physician in emergency medicine, practicing clinically at Atrium Health in Charlotte, North Carolina. I'm also the co-founder and CEO of May-June, which is a startup that makes healthcare-focused apps, and through which the Firefly packages have been created, which is a global collaborative. Just to give a very quick 1-minute intro of the, or 30-second intro of the Power BI keynote that I gave on Tuesday. Like Michael Wang, I am very heavily embedded into the data that are available from the clinical side into our electronic data warehouse and built some visualizations from that. I'm also a Google developer expert in Dart and Flutter. If you've not heard of Flutter, it is the open source cross-platform UI toolkit that you can use to make Android, iOS, web, Linux, Windows, and Mac applications, and Fuchsia whenever that's released. There's over 100,000 apps on the Google Play Store. It's about 70 Flutter GDEs that exist in the world, and I'm the currently only healthcare person. Liz gave her keynote talk about Prepare, And this was one of the applications that we developed as a collaborative, harnessing Firefly packages so that it can use Fire as a whole. If you think any of the developer discussions that we have from the clinical side are interesting, then I would encourage, we actually have a hackathon that is coming up in collaboration with the company, where we're going to specifically look through Fire data and see if we can take an approach that can harness Fire and patient safety to improve the patient experience. And it is slated for July 9th through 11th. That's me. I also have a YouTube channel, and I love designs as well. So Figma is right up my alley when it comes to making cool interfaces. But I'm happy to take the doctor perspective as well as what I can for dev. Thank you.
So if you could skip us back to slide 1, John, and we will go into discussion. So since you're up, I'll start by asking you, what do you want from developers?
Very good question. I think, as I've looked through this from the lens of a clinician, a designer, at least as good as I can, and as a developer, I think from the developer perspective, the immediate next step is I think we need more developers. And I think that we need to ease the barrier as we are getting people into Fire in building out healthcare solutions. To give an example within Flutter, everything's a widget, great. One level down is a stateless widget. The next is a diagnosticable. And I don't know anything about diagnosticable, but I know how to use stateless and stateful widgets. And I certainly know how to use the things that are built from that, like a text box or a row. And as I'm looking through what the last 10 years of Fire have become, we've essentially built that entire foundation through which others can now utilize. And I'd argue, because I'm biased here, but I think Firefly is a nice opportunity that shows how now you have that next layer of abstraction. And I think really that we need to be adding to the conversation from that higher level of abstraction so that we're doing this in a more declarative programming format rather than imperative.
Oh, excuse me. I just realized Katie's flight is boarding in a few minutes. Do you have anything you want to ask Ewout or developers in general?
Oh, yeah, sure. And thanks, John, for that. I don't speak developer, but I understood about 40% of what you were saying.
Sorry.
And that's okay. I'm sure the audience totally understands. So yeah, a few ideas, and maybe these are things that have come up in the past. The first thing I want to mention, and the reason why I think what I've been working on ends up being pretty different from other solutions that exist. One, I'm a patient myself, and there's such strength in partnering and working directly with patients to collaborate on solutions. I know you've probably heard that before. Sometimes that can be hard to put into practice, and as a user experience designer too, and a researcher, it's something that I have to struggle with too, is how to pull people into my process. And there is a cool company called Savvy Co-op, Savvy Patients, and their whole business is finding you patients to collaborate with on your projects. So I just wanted to call out Savvy Co-op, I think it's called Savvy Co-op, as a resource for pulling patients into your project. So I think that's really important, just to really solve end users' real problems. And sometimes that might mean breaking free of or kind of breaking out of existing data structures and thinking about new types of data to pull in that might help us solve some of those problems. So some of the things I have been including in these visualizations that have been really core to people's stories that I think should be considered for as opportunities of including in our health data representations. On the technical side, our symptom history, mental health and physical health symptom history, symptom quality, so like how patients' bodies feel, even work history, which I didn't talk about earlier today, but our work history can actually have a lot of overlap with our health history. Stress and past life events have been very core and vital to health history. And then when I was talking a little bit about medications, not only the prescribed medications, but just anything that you've tried, or any treatment, anything you've tried to feel better. And one thing I've noticed when I've seen my health record and other kind of health data representations, when it comes to medications, a lot of times you're pulling that information from maybe the insurer or from the health record, and you can see when that medication was prescribed, but was it actually taken? And I guess the kind of my whole ask is to allow patients to be the ones to perfect the health data and the health record, because they're the ones who have all the information. They know if they actually took that medication or not. They know if it helped or not. So yeah, that's it in a nutshell.
So Ewout, we out here in the patient world keep wanting the industry to look at things from our perspective and make sense to us. What do you say from a developer's perspective to what they just said, what Katie and John just said? What can, in a roundtable sort of a sense, what do you want to say back or ask for from them?
So I think the interesting thing is that Katie is talking about what the patients and maybe the developers helping out patients by writing apps want from us developers, and sometimes I feel that's a bit different from what we can do, and it's almost an ask that I have to doctors and hospitals. I do remember that I once was involved in writing an app for brain tumor patients. And we had exactly the kind of information that Katie is talking about, which means much more of the social context. So the patient would keep track of how they felt, their nausea, their dexamethasone doses, and so on and so on. And we offered all that stuff in an app to the doctors, and the doctor said, well, it's not my data. I actually don't want to see it because I don't want to be responsible for it. So me as a developer was suddenly in between the doctor and the patients, which is funny because if I put on my hat, not as a client developer for this brain tumor app, but as a server developer, which I am at Firely, I had two roles there. I actually knew this was going to happen because I'm normally involved in writing the solver on the EHR side. So I already knew what kind of problems there I would encounter there. But it was pretty frustrating for me as a client developer to not be able to say, oh, I've developed Fire. I'm now writing a client app. I'll just make this work for a brain tumor patient. So I hit my own brick wall there, actually, that I knew was there. And so this was, of course, because I knew we couldn't easily get the data from the EHR because it wasn't there, and we couldn't easily get the data out of our app into the EHR because there was no place for it to put it there. So that was my personal experience in dealing with the things that Katie was talking about.
This is the case for human factors and usability, because if you think about it and Michael Wang just described this earlier, how much of your time is available when you are spending 3 hours every day catching up on your documentation or whatever other administrative tasks that you have. And then you say, okay, let's add more. Well, a little bit of adding more done 100 times is a lot. And this really, I think in many ways, a lot of the technical tools that I see on Shift, personally, I think the workflow does not match what we do. And there's definitely a lot of opportunities when you're looking at embedded usability and human factors specialists who see what the work is as done. You could use the lean process term, go to the Gemba, the place where business is held, and evaluate that, and then take that perspective to see what opportunities there are moving forward to make this easier for patients and for providers. And by provider, I mean clinician, you could be nurse, tech, any of the staff that care for patients within the care settings that exist in an outpatient setting or in a clinic.
So, it's interesting. So in the e-patient movement, Empowered Engaged Patients, we've been working for 10 years to get doctors to welcome us asking questions and sharing in the doctor visit information that we found online for their comments. And for the first few years, we knew the resistance we got was from the older doctors who just were never trained how to deal with this kind of person. And so they started retiring, but now we're finding that brand newly trained doctors often will push back because they don't have time. It takes more time to do that kind of stuff. And I wonder, what I hear both John and Katie talking about, and I think I heard some of from Ewout, is it more of a burden to do this kind of interaction, or is it a necessary part of chasing true north?
I have some stuff to say to that. I think one thing that I've found in the work that I've done with Pictal is it actually takes a burden off the doctor, and it can be time saving to be able to review all the data in a more consume it in a more user-friendly fashion. So we can actually, if we're doing this right, if we're including human factors, as you say, John, and kind of a human-centered design process, and really getting at some of the core problems and trying to solve those problems for patients and for doctors, we have a big opportunity to make everyone's lives easier and hopefully create an environment where doctors are willing to take the time to try something new, to check out these new tools, because hopefully they'll start to see, if we can do this right, they'll start to see that it's going to make their lives easier and help prevent some of that burnout.
When you look at it, and I agree entirely. If you look at it from the perspective of what the conversation has been on the clinician side, and I'm happy to provide additional information for people that reach out to me. But Christine Sensky from the American Medical Association gave a wonderful keynote talk at a informatics conference earlier last month, talking about how this leads to burnout, how the amount of time that we are spending add to your cognitive burden. And there's NASA has a good survey that you can do that only has a few questions and helps you understand cognitive load. And then there's time on task things as well that you can use. Putting it a different way, just from my personal perspective, I was a medical scribe handwriting patient charts in Washington, DC, back when, for 6 months, we were handwriting charts in an emergency department. And I was writing in the medications and laboratory results and the history and the patient's exam. And then 6 months in, we transitioned to an electronic record. And our only role as a scribe was helping our providers originally document less and then click less. Whereas on the other side, I was also a tech. And helping our nurses with the procedures that they were doing. And having seen that, and having seen different iterations of EMR integration over, however, I think that's been about 15 years now. Really, I think that those usability discussions to actually embed people who understand what those workflows are, so that then that barrier to design is minimized, and then translate that over into development opportunities. I think that is really the twofold approach that I think really would shine. Lower the barrier to entry of what work is as done, and lower that barrier between design and development.
So thank you both. We're down to our last couple of minutes, and I'd like to ask Ewout, both as one of the most senior people in the FHIR world and as a developer, what I think I'm hearing here, what we're asking for developers, from developers, I don't know if our audience, the people attending DevDays here, it sounds like this is not at the level of how can we better do the things we're doing, but at a level more of, are we doing the right things? And I'm stammering because I don't know how to think like you. So how would you wrap up this whole discussion? What guidance would you have for our audience?
Well, I personally, I feel there is a gap between. So I can point at myself here as a standards developer. I've been thinking about data models, standardization of these things, and storing them in machines. While there is a large group of developers that are, which have been for a short while when I wrote this app, that are more at the patient side, the doctor side, with UX design, the whole flow of dealing with treatment and so on. And I think there's a disconnect there. If you look at these hackathons that John was announcing, most of these people are really focused on solutions and close to the patient, and they think that the last thing they need to do in the last few days is get the data somewhere stored. But you know, that's a trivial thing to do. And we here, a lot of us at DevDays are actually on this other side to say storage and standardization is a really important thing. So please come to us and let's connect there. And I think that that we as developers still need to connect these two worlds of more the hackathon developers and the standard developers, back-end server developers that I am more a part of. That is what I've taken away from a lot of discussions this week.
Wonderful. So Katie, thank you so much for doing this from the airport on the way to go see your mom for the first time.
My mom and dad. Yeah, I'm about to fly off to Michigan.
And John, thanks. And thanks to both of you for your terrific talks. And at this point, we'll hand it over to Graham for the closing keynote.
Thank you.
Well, hello, everybody. Let's just wait till I get focus here. Thank you. So hello, everybody. You know, I don't remember how many keynotes I've done. But yes, I think I've keynote closed every single DevDays. And look, I love DevDays. It's my favorite conference, really. I mean, of course, it's Fire Conference, so I've got to love it. But I've always thought it's one of the best organized conferences that I've got anything to do with, irrespective of the fact that it's Fire. So once again, I want to start by thanking thanking Viley, Rian and the team. Amazing work to bring this together. I've really enjoyed the pub talks. I do wish that I wasn't doing the pub talks so I could go to the other pub talks as well. But you know, you can't have everything in life. Dave was excellent last night. Love Dave. It was excellent. And in fact, I will blog about Edmund Fitzgerald. So keep an eye on my blog for the Edmund Fitzgerald piece. And the keynotes have been excellent, amazing pulling power. I love the keynote speakers from outside the community, and particularly the doctors that gave their personal time. So it's great. Now, I was talking to Rian about this before, and obviously virtual conferences, not as good as real conferences, but heaps easier to get to attend. You don't have to travel. And you know, I mean, I didn't have to travel, but I did have to actually flip time zones. It's now 7 minutes to 7 in the morning for me right now. I've been awake all night. It's not that fun. It's not much fun. Which is worse, flying and changing time zones or not? I still haven't figured out. But Rian suggested that I ask you, how do you think we can transit back towards a new normal with virtual conferences or real conferences or a mix, pros and cons for both options? I kind of feel as though everything in life is more efficient now, all of the routine stuff, because we don't have to travel, we just do it by Zoom or whatever. It's actually easier and quicker and more efficient. But the big things in life, creating relationships, friendships that can really influence people's behavior, I really miss doing that face to face. And I wonder whether it's even actually happening at all in some ways. We seem to be just waiting for it to go back to when we can do that. And maybe there's a tension between those two functions of a community. So when we go to drinks, feel free to find one of the Farley team or me or one of the HL7 team and give us your opinion on virtual conference versus real conference and strengths and weaknesses and how we can balance that. Now, obviously, this year is 10 years for FIRE. You've heard plenty about that. So just a little bit of background to that. We were working on version 3 and CDA, and I was just looking at that thinking, you know, it's just not meeting the need. And I can see the web coming at us, and I can see that we're going to be, everybody's going to be looking for a web-ready healthcare data solution. We're not in the running for that. And I had a contract fall through, and the contractor, the Australian government, said to me, well, we don't want you to do anything else. We don't want you to go and get another job, and we'll pay you once we can finish off the paperwork. But I knew it was going to be weeks before they got around to that. So I wasn't allowed to go and do anything. So I said, right, this is my opportunity to actually invest 4 to 6 weeks. What would I do differently? If I did something different, why? What would I do and why? And so I came up with something I called Resources for Health, RF4F, FH, sorry. And drafted that, spent a little bit of time learning and researching what would I do. And I published that. I just want to show you the very first email I got concerning that from someone. Here it is on the screen from Ewout, August the 17th. That's the 6 weeks is up, see, and I've published it. And I've asked for comment from a couple of close friends, and Renee passed it on to Ewout. And here we are. And it's quite funny, actually, because he says he's got one maybe fundamental issue, which I pretty much think we still haven't nailed. So it's pretty funny. So that's the very first email I got from my work on FIRE. I think I got one from Lloyd the day after. Might have been the day after that. And I think that was the sequence that it had. So anyway, that's kind of ancient history for FIRE. So I thought you would enjoy seeing that email. And that was back at Ewout to be working on something called Smurf, which was pretty similar concept. So anyway, it was wonderful and really, you know, creating a new idea, working something up from scratch. There's long periods of self-doubt. It's the way that HL7 works, the way that I worked. I don't know whether it has to be like this. You tend to have periods where you're off just doing grunt work. You head down doing the incredible amount of detail that's necessary, and then you meet with people and you either get criticized, you either get endorsed. And it's in the periods between the feedback, the human feedback, where the periods of self-doubt accumulate. And they certainly did for me. And I had, you know, I could track my moods, a roller coaster from when I was working it here in my office at home, which where I usually work, this little 3x3 shed in the backyard. And it could be pretty gloomy and dark out there at the moment. And then suddenly you'd go off to a meeting and it would be, you know, intense and exciting. I think there's something I learned through that process, which is that there is those times of doubt. But if you have a good idea and you really commit to it and you follow it and you push through those times of doubt, then you will get fulfillment. Of course, it could all go completely wrong because you're not doing the right thing, but it certainly, those times of doubt were real. Of course, I don't really get times of doubt so much these days. But in that 10 years, we've started. I remember we met, Lloyd, Ewout, and myself. We met. It was just the three of us in a hotel in San Antonio, under the stairs. And we laid out a bit of an agenda. The agenda wasn't as organized and clear as it seems now, but I knew that we wanted to do three things. We wanted to disrupt healthcare IT standards. We wanted to disrupt healthcare IT, and we wanted to disrupt healthcare. And I pretty much feel as though we've finished the job of disrupting healthcare IT standards 4 to 5 years ago. the standards that are not FHIR are busy trying to compete with FHIR in terms of building community, getting the license right, providing good examples, good implementation collateral. Those are the core ideas of what is FHIR. And so we kind of did that. Then we said we wanted to disrupt healthcare IT. And I see in the community that we have tilted the playing field towards interoperability much more. Some kinds of interoperability have significantly transformed, others not so much. There's plenty of work to be done, but you know, you can see products sliding towards interoperability as an expectation rather than something you pay to add on to it. But the thing we wanted to transform was healthcare itself. And you can still see that that's just getting going. It's not going quickly, but it is getting going. And I've taken some heart from this, you know, the keynotes in particular at this talk, but also some of the other talks. It's it's starting to get going that we're bringing pressure to bear on the healthcare system itself. And when I look at what's happening through the FHIR ecosystem, I look at two particular trends that are really going to be significant, I think, in the next couple of years in the FHIR ecosystem. The first is IPS. This is not so much a US concern, and this is the US DevDays, but IPS is starting, there's the International Patient Summary and related work around that is really starting to get some actual traction outside USA and even a little bit inside USA. And so you're going to hear a lot more about that as an international agreement around which people can converge and exchange data. So that is certainly going to happen. I'm really excited about that. And the other thing that looks is really significant and is suddenly starting to get real impetus and I think will be transformative is the work around smart health cards. So I'm really excited to see that positioning and the energy around that community. And I'm really looking forward to seeing that being brought to bear across the picture. So what is it we need to do? What is it that stands out? There's been a lot of talk in this conference and some ongoing theme. I used to talk about the 5-5-5 rule, which was something that was sort of had credibility a few years ago. When you run into a new interoperability specification or whatever, it's a 5-5-5, 5 seconds to find it, 5 minutes to understand what it's doing, 5 hours to have something working. And we had a presentation about Matrix before, and the keynotes earlier. I never heard of Matrix before. I probably should have really, but I hadn't heard about it. So I looked it up. Well, it took me more than 5 seconds to look it up because you know how many uses of the word matrix there are. But once I found matrix, then it took me about 5 minutes to figure out kind of what it was. Although I can see that login is going to be longer than 5 minutes, and probably I'd have something sort of working in 5 hours. So that's kind of how you think about this. But I used to say that with healthcare, there's another 5 years to begin to understand healthcare. And so many of the problems people have, it's like, how can it be such a mess? And those of us who live in healthcare go, well, duh, that's what we do. That's what we live with. And why? I mean, partly it's the tyranny of legacy data and legacy systems. And we're all confident that HL7 version 2, which HL7's been trying to shut down for 10 years, ineffectively, will still be in use in 50 years' time. It's really, really slow to change things, and we're in a mess. And it's not just legacy systems, it's legacy data. It turns out that clinicians, clinical providers, care providers are kind of like having the records they have of their patients. Do you know how much easier the system would be if we just said, get rid of all the records and actually build a clean set of records from scratch? That's something this is never going to happen. And so we just have to get with that and say that healthcare data is going to continue to be a shocking mess. But it certainly does underscore for me the absolute key. You might differ, and I'm happy for you to tell me if you think I'm wrong here, even when we have our drinks after this. But my opinion is that fire is a reasonable best shot at what interoperability looks like at the technical level. I mean, there's some people who argue that we should have more modeling or should have more rigor in some ways of information representation. But all of those things assume the healthcare system we don't have. The problems that we still have are the next level up. And so I think our attention increasingly needs to be focused on getting clinical agreement around clinical consistency, information consistency. HL7 is very much in the situation of having everybody turn up going, well, this is what we do, so you have to make that possible. And somehow, and I don't know how, we have to turn that over and actually get to real standardization. And I know people say that fire has held that back, and we deliberately did so we'd actually get solutions that worked, messy, but working, over perfect and not in use. But somehow we do have to start chipping away at that and leveraging that and tilting things. A couple of other things I want to talk about. I mean, clearly a clear focus for us as time has passed and the fire community has grown larger and more influential, much more influential than I expected we would ever be, is building good relationships with other communities. Particular focus in the last couple of months is around OMOP. We had some discussion this week around OMOP and to a lesser degree open air. Seems to me that we need, I would like to have a better technical answer to this. And we have an OMOP project now that we're looking to start moving forwards. Hasn't happened yet, partly my fault, but let's move that forward. I do think that we have to come to terms with understanding the difference between an approach like OMOP, which is around shoehorning the mess into a consistent structure on the basis that the mess doesn't matter, and fire, where we go, the mess absolutely matters for getting it right operationally, and we can't escape that. I think that there's a price to be paid for the cleanup that somehow gets swept under the carpet. And I feel as though we as a community need to spend more time standardizing ETL work. And there's a bunch of ETL kind of work happening around mappings and data modeling around V2 to fire and CDA to fire and OMOP to fire and back and so forth. Feel as though we've got a bunch of work to be done there overall as a community to make that easier and slicker, because, you know, those are the two great questions for implementers. One is, why is this such a mess? Why is this all so hard? And the other is, I just need to move data around and it's just still too hard. Obviously, the other focus, it's not really the focus of the fire community. My attitude to the focus of the fire community is any way to exchange healthcare data. Any healthcare data exchange is good for people. And so I don't mind what healthcare data it is. But as we move into the world of consumer access to data, and you can imagine people starting to target healthcare data online. Hey, give us your healthcare data, and it turns out they're not a good faith actor, or it turns out they're both a good faith actor and not a good faith actor, which probably be the hardest cases to deal with. What is ethical use of fire look like? What does ethical development of fire look like? When is progress bad? And there's a real political argument around vaccination certificates. I think they're doomed. Just as my observation, people just won't tolerate fractionating society like that, even if it's probably a good idea from a health perspective. But you know, that's just a personal opinion. So that's another thing that you could talk about over drinks is what ethical considerations are there? My view has always been the problem with the digital transformation arises where there are not open standards. And if you look across the areas where society is concerned about the impact of digital media providers, the influence of them, it seems to me that it's always where there isn't open standards. So that's why I'm particularly dedicated to open standards. But hey, have a chat. Tell me what you think. So thank you for listening. Thank you for being here with us. I hope I see you again. One day I hope I see you in person. I certainly would love to do that. Thank you for being part of the FIRE community or some related community. And I encourage you all to continue to give to a community and create open standards. And thanks for time for me to stop and hand over to Wayne. Off you go, Wayne.
Oh, and thank you, Graham. And you win this year's Iron Man Award, as usual. It's been a haul this week. What a week, what a day. We've had some incredible keynotes. Certainly they've had me thinking of quite a few things. We've had an incredible wealth of knowledge shared by our speakers. And you know, I want to remind you all that most of these sessions have been recorded, and those you missed might be worth a look. And some are definitely worth another look to go back again to remind yourselves, because this is important stuff. And I'm always amazed by how much we get out of DevDays. But you really don't need to see it all either. You know, to paraphrase Gray from Monday's keynote, FIRE has something for everyone, all 7.6 billion of us in terms of what Graham wants to do in changing the world of healthcare. And so I encourage all of you to take what you learned this week and apply it, and come join us at HL7 and join us in the FIRE community if you haven't already, and really help us to continue this great work, because this is really, in many ways, one of the most important things that we can do for the world, really. And closing up, I would like to once more thank the HL7 and the FIRE team for putting together an incredible meeting and running an incredible meeting. Every time we do these, we get better, but this was one of the most polished and smooth ones we've had yet. And thanks to you speakers for joining us, and thanks most of all to all of you for joining us here today. I guess at this point, it's time to move over to Spatial for a farewell drink. We're gonna have a 5-sweet toast. We'll kick it off here, but just do come join us over there. And here's a toast to a more healthful world on FIRE. Thank you all for helping us to make this such a great success. See you in a bit. Bye-bye.
Thank you, Wayne.
Bye. Bye-bye. Bye.
Bye.
Thanks, guys. Thank you,
Thanks.
Marisa, too.
Thank you, Graham. Thank you, Marianne.
Yeah, thank you, Marianne.